I chose to think about oligometastatic versus oligoremnant disease by first highlighting what have we done in terms of clinical trials to show that there is a benefit of local therapy in the setting of oligometastatic non-small cell lung cancer? So, I prioritized looking at 3 trials, Gomez et al., Iyengar et al., and Palma et al. And each of those showed that when we add local therapy to an oligometastatic non-small cell lung cancer setting, you get an improvement in progression-free survival, a very significant improvement in progression-free survival. And 2 of those studies showed an improvement in overall survival. But there were relatively small randomized phase 2 studies. And so now we're in the era of the phase 3 studies, one of which is LU002, NRG-LU002. It has enrolled the most patients of any oligometastatic trial to date across any primary cancer, and especially in non-small cell lung cancer. And that trial is really asking the fundamental question: in patients who receive IO-based systemic therapy as a first-line therapy, will the addition of local therapy help overall survival? And so we've enrolled 218 out of a planned 378 patients evaluable. We're in that interim analysis, and we're waiting for the outcomes of that phase 2 interim analysis for PFS benefit. But in the meantime, what I wanted to argue that I think that oligometastatic and oligoremnant, though appropriate definitions for certain situations within the greater context of oligometastatic disease, really are really not detailed enough for us to understand how to apply local therapy in a personalized fashion. And so what I mean by that is that, as I said, oligometastatic and oligoremnant disease definitions really describe a snapshot in time. But we have no idea that once we give the local therapy that these patients will met out to numerous sites, suggesting that the addition of the local therapy was never going to be a benefit for that specific patient to begin with. So my argument in this presentation is to push for the idea that we need to better understand ctDNA changes in the serum, minimal residual disease levels, do better job of understanding the oncogenotypes that are associated with tumors and drive a true oligometastatic state, and also starting to better understand how the host tissues respond to these disease states as well as the therapies, in order to make sure that we are really capturing the right patient population as we move forward in trying to optimize local therapies for the management of oligometastatic disease.